Hello, everyone. Thanks very much for coming out. I think it's probably going to be a small crowd tonight. It's such a beautiful day, finally, from this long weather. My name is Denise Vigneault. I'm with Howard Center, and welcome to Scattered ADHD Across the Lifespan. It's our third and final session in our spring series, but we will be back in the fall. The format tonight will be about an hour presentation by our two wonderful physicians, and then we'll open the floor for questions and answers. Once we do that, I will come around with a microphone and we'll ask you, even if you think you have a loud voice, to please use the mic, because we also have a video, and that will be posted on our website and on the VCAM site within a few weeks, and it's a much better quality if we use the mic. So we'd appreciate that. I want to thank our sponsors, Jerry Riley Real Estate, our presenting sponsor for the spring series, VCAM, who is here in the room. We have Ken and Athena in the center. Thank you both very much. And our host sponsor, Dealer.com, they generously opened this wonderful site to us. Restroom is in the lobby. If you need to use that, we have people right outside the door that can help you get there, and there's actually one in the back as well. And then also, if you need to come and go, that's okay. We'll help you get out to the front of the area. A couple of other notes. In your folders, you'll see our spring conference on opiates, which is on May 22nd. Please share, please register and come. This is intended to be an educational community event. Also, you'll find suicide prevention resource booklets in your folder. If you need additional, please just give us a ring. We can ship 50 to you, whatever it is that you need if you're an educator and would like them for your classrooms, your family, colleagues, whatever you need. Please be sure to complete the feedback form that's in your folder, and I'll try to remember to prompt you to do that too. It's really important because we actually read them and we select our topics for future events based on what you're asking for. So without further ado, I would like to introduce my two colleagues. I'm couched in between them. Dr. Feyza Basoglu graduated from Istanbul University School of Medicine after being inspired by her high school psychology teacher and the many physicians in her family. She left Istanbul to attend the University of Massachusetts for training in adult psychiatry, followed by a fellowship to study child and adolescent psychiatry at the University of Vermont. Dr. Basoglu works with patients at Howard Center and the Counseling Service of Addison County and says, I learn, grow, and transform with them through this very humbling experience of understanding the developing brain. Welcome. Dr. Joe Lasek, he's been here a few times before, ever popular. He's the Associate Medical Director at Howard Center, where he's been working for more than a decade. He's also a clinical assistant professor at UVM Medical Center's Department of Psychiatry and an adjunct faculty for Southern New Hampshire University's graduate program in clinical mental health counseling. He's worked in community mental health, corrections, and in inpatient psychiatric settings over the course of his career. So welcome to you both. Thank you very much for being here. Let me get the slideshow up. Let's see.
Thank you. All right.
Do you want to use the pointer?
Probably not. I'll just leave it there. It's fine. Thanks. Thank you all for joining us this evening. So we'll be talking tonight about attention deficit hyperactivity disorder. I'll talk for the first part tonight, and then Feyza will take the second part. We're going to cover a few things today. We're going to talk about the prevalence of ADHD in our society. We'll talk about some conceptions as far as diagnosis is concerned, including some nuances in the assessment process. We'll talk about ADHD as a developmental disorder, one that presents differently at different ages. We'll talk about some possible treatments, and along the way we're going to touch on some potential controversies. First start by talking about how prevalent is this thing we call ADHD. As we currently define it, it is a fairly prevalent condition, and I included other common psychiatric conditions by way of comparison. And you can see that amongst children, it's one of the most prevalent of the psychiatric disorders. And that decreases during adulthood, but still remains fairly common, about as common as other well-known conditions like depression, PTSD, panic disorder, bipolar disorder. At one point, it was thought that kids who had ADHD did not continue to have difficulties into adulthood. When we began doing better longitudinal studies, we found that was not the case. About 40% of children followed through adulthood will meet full criteria during adulthood. 25% of people will be partially symptomatic in adulthood, and about a third will meet condition for full remission, meaning they don't meet the criteria as we currently define it. That group in that 25% category can go either way. There still can be some significant impairment due to the problems with attention, hyperactivity, or impulsivity. And it's not always clear how to best help those folks, but usually made on a patient-by-patient basis. But it is pretty well established now that this does continue into adulthood and continue to pose significant problems for people as they get older. Sometimes ADHD, people think of this as just hyperactive kids, active kids, or people who are a bit scatterbrained, and this really isn't that significant an issue. We're pathologizing kind of normal behavior, and when you really strictly define what ADHD is and then see what kind of things are happening in these folks' lives, you see that is actually quite impairing for people as they go through childhood into adolescence and adulthood. People with ADHD have been found to have poorer health and health habits, decreased education and occupational achievement, more difficulty in relationships, more difficulty maintaining relationships, higher rates of divorce, more problems in the legal system, problems with missing appointments and deadlines, problems with managing money, increased rates of bankruptcy, increased rates of stimulus seeking and resulting injuries, problems with driving, higher rates of motor vehicle accident, and higher incidences of road rage. There's, again, this wonder by many that, is ADHD overdiagnosed, overtreated? When I started learning about this maybe 10 years ago, when I left training and became more familiar with it in my practice as an adult psychiatrist, it really had fairly recognition that this continued into adulthood was fairly low. And mostly driven by drug company advertising because of new agents that were promoted and realizing there was a market here for some of the medications that are available for ADHD. There has been a lot of promotion in the media about ADHD. And so there is a very reasonable question I think any one of us can have is this overdiagnosed, overpromoted, overtreated? One study here was a nice review that was done last year in the Child and Adolescent Psychiatry Mental Health Journal, looked at overdiagnosis amongst children for a number of psychiatric conditions. And what they found was that according to the criteria that we have come to by consensus in the psychiatric field of how to define ADHD, anxiety, depression, et cetera, that most conditions were quote-unquote overdiagnosed, that when you take kids who have been diagnosed with the condition and then apply strict criteria, many of them no longer met those criteria. And for ADHD specifically, in the 2 or 3 studies I looked at this, 16% to 41% of kids in these studies did not meet criteria on close review. So there was overdiagnosis in those studies, and there's also a bit of underdiagnosis, and that 7% of the kids that were missed did meet criteria, but definitely in those studies, overdiagnosis was a problem. The authors suggested that when they looked at the factors that probably led to that, what they found was that clinicians were not applying the criteria strictly and correctly, and that they did not revisit the diagnosis in an ongoing way. So the recommendations were to do that when I'm meeting with somebody for the first or second time, you get an idea, I get an idea what's going on, and make a hypothesis. I say, I think this probably best explains what's going on for you, but it's always an ongoing evaluation. And if we find better explanations for a person's difficulties, we want to go back and revisit that diagnosis. And that's what these authors do, recommend. One study, this is from 2006, looked at, this is focused on adults with ADHD, asked a question, looked at people in the general population and looked at a number of mental health conditions. Again, this data is about ADHD specifically. And what they found was that about 56% of people had told their health professionals that they were working with that they had symptoms consistent with ADHD, but had not been diagnosed with it. So there was, in this one study, underdiagnosis in adults. And amongst those adults who met criteria for ADHD, only 40% of those folks had received treatment. So next I'm going to talk about ADHD assessment. How do we go about assessing people who come in to see us for possible ADHD? And the current state of the art is we perform a clinical interview. We are going to review all possible symptoms and presentations for a number of common psychiatric conditions, including ADHD. To assist in that, we might use rating scales. I don't use this with every patient, but do find that they are generally helpful in getting more information. And for those cases where it's not entirely clear, either from a patient's history or their current functioning, that how much these potential symptoms are having impact on their life, I think rating scales can be quite helpful. We're going to ask about how often ADHD symptoms are occurring. And we're going to tie this to functional impairment, and that's a diagnostic requirement, and it's very important to understand if somebody's having inattention, restlessness, hyperactivity, or impulsivity, how that's impacting their life and their functioning. We're going to do a very careful psychiatric and substance use history. We're looking here for what we call differential diagnoses. Are there other conditions that might better explain why a person is currently in distress? Are they using substances to self-medicate? Very common, as I'll talk about later, for people with ADHD to use substances often to self-medicate. We're going to ask about childhood history and developmental history. When do these problems start? How early? How do they present later throughout their life? ADHD has a strong genetic basis. I'll talk about that in a bit. So family history is important in trying to make a diagnosis. And rarely do we refer people for formal neuropsychological testing. I think, Feyza, you were saying that you might do that more than I would typically do. I typically refer for neuropsych testing if there's a concern about a comorbid condition like a learning disability that I want to learn more about, or maybe there's a comorbid traumatic brain injury. I want to understand how that might have impacted somebody's neuropsychological function. Or if it's not quite clear, it might be a confusing picture. Sometimes seeing a neuropsychologist can help us on the clinical side figure out what's the best way to kind of explain what's going on and develop a treatment plan. So the DSM-5 is our current diagnostic manual that we use in psychiatry to help make a diagnosis of ADHD and then institute treatment. And when we do that, there are two domains of ADHD. One are the inattentive symptoms. The other domain are the hyperactive impulsive symptoms. There are 9 symptoms in each domain. And if you meet, as a child, if you have 6 of 9 of those symptoms in either domain, you meet criteria for an ADHD diagnosis. As an adult, you'd only need to meet 5 of 9 criteria. And that's because as we age, all human beings tend to have less issues with inattention, impulsivity, and restlessness. And therefore, to pick those people out who are kind of on the extreme end, in the top 7 to 10% of people who experience inattention and hyperactivity, you actually have to reduce the symptom criteria to 5 of 9 for adults. These symptoms include things like failing to give close attention to details, difficulty sustaining attention in tasks, Difficulty listening when spoken to directly. People often with ADHD often become distracted, look away, don't remember what people are saying when they're being talked to. This can lead to problems, say, in school or on the job. They don't follow through on instructions, fail to finish tasks. People often describe having a bunch of tasks unfinished at home and being very overwhelmed and frustrated by that. They have difficulty organizing. I often ask people about their filing, their taxes, their checkbook. How are those at home? And that often they're in disarray. They often avoid tasks that require sustained mental effort. So procrastination, chronic procrastination, waiting to the last minute is a problem. Losing things necessary for activities, keys, wallets, glasses. People with ADHD often have problems keeping track of those. Being easily distracted. This can really be a problem, in work and school environments, and being forgetful in daily activities. The hyperactive impulsive symptoms include things like fidgeting or squirming almost constantly. Often when people come to see me, one of the first things I'll see is that their legs and hands are going almost immediately, even though they may be sitting kind of quietly in a chair. Most often there's some part of their body that's moving throughout the interview. People with ADHD often leave their seat in situations where it's inappropriate, say at a restaurant or a dinner table or at work. They often describe feeling extremely restless. Subjectively, what this often is reported to me as is anxiety. I feel very anxious, and it takes a little bit of discussion to see whether this is, in fact, restlessness, which is more of a body-centered discomfort, feeling of having to move. They often have difficulty engaging in quiet activities. They might describe themselves as feeling continuously on the go or driven by a motor. They often talk excessively and speak impulsively. Difficulty waiting their turn. So they often describe, plenty of people with ADHD who say, if I go to the supermarket and there's a line, they'll leave their whole shopping cart and leave the store because they can't stand to wait. And they often intrude on others. And this can be very socially difficult. People don't like being intruded on or interrupted, and people often feel a lot of shame about this. They think that they're being very rude. They've been told they're very rude. In fact, it's an impulse control issue that they have very little control over, even though they try very, very much to do so. And just one point here I'll make is that the DSM labels says that to meet criteria you have to often have this problem. Often is a clinical judgment. There's no criteria. I tend to interpret this as daily or multiple times a day if a person is having this issue. But there is some subjectivity to it. There's some subjectivity to some of the other criteria, not the first one. There is an age cutoff in DSM-5 says that you have to present with these symptoms before age 12. It used to be age 7, but that criteria is relaxed based on some research that's been done in the last few years, that an older cutoff age more appropriately captured those people who we consider having this diagnosis. That the impairment has to be present in more than one setting. You can't just be, you have problems with attention, distractibility in school, but not at home, or vice versa. If that's happening, then we really want to look at what the school environment is like or the home environment is like, rather than saying that a person has ADHD. There has to be clear evidence of clinically significant impairment in social, academic, or occupational functioning. Again, what's clinically significant impairment is left somewhat up to clinical judgment, but it's pretty clear. Somebody's telling me that I've held 30 jobs in the last 2 years, or my boss is telling me I'm going to get fired if I don't stop messing up the change drawer, or things like this, that this is now interfering with their life in a significant way. And what I'm looking for is this happening in multiple settings. And then finally, here's where the most clinical judgment is involved, which is it does not occur exclusively during another condition. We as clinicians have to decide when somebody presents us with an array of symptoms and difficulties in their life, what's the best way to account for this? There are several conditions that can lead to concentration problems, to feelings of restlessness, a lot of anxiety disorders, for example, post-traumatic stress disorder, sometimes depression, sometimes there's medical conditions that can do that. And what we have to try to do is, using our clinical judgment, find the best explanation for why those people are presenting the way they are. And sometimes we're wrong initially, and we have to, again, keep revisiting that diagnosis to see what makes the most sense. Some symptoms that are not in the criteria for ADHD have long been recognized as co-occurring with these other symptoms. Some of these symptoms have been described back as far as 100 or 200 years ago when the first descriptions in Western literature are found describing children initially who had hyperactivity and inattentiveness, but also seem to have issues with emotional difficulty, what I think of as emotional impulsivity. So it's not just impulsive behavior and impulsive speech, but also impulsive emotions. So people with ADHD tend to have strong initial emotional responses. They have difficulty moderating their emotional states and difficulty self-soothing and coping. And so this is one, these difficulties are one reason that people with ADHD are often diagnosed with bipolar disorder, another psychiatric condition involving mood ups and downs that tend to be sustained over time. So people might experience days, months, or weeks of either episodes of increased energy, decreased sleep, impulsive behavior, but then they come back to a baseline and then they might become depressed for a while, for days, months, or weeks. ADHD, you might see emotional impulsivity on the order of minutes, hours. And sometimes these people are called rapid cycling bipolar. And I found that most people who have that kind of mood ups and downs, they don't have bipolar. They might have ADHD, they might have post-traumatic stress disorder or another condition, but it's commonly seen in ADHD, this emotional impulsivity or emotional lability. People with ADHD have impulsive motivation and arousal. They have higher states of state and trait anger. State anger meaning baseline, more prone to anger. Trait anger meaning more episodes of anger, more easily angered. They have more of a tendency to act out violently, and they have higher rates of road rage. Also not commonly recognized, even by clinicians that I consider to be quite experienced, are the fact that people with ADHD can experience sleep problems, and sometimes very significant sleep problems. I've had folks with untreated ADHD, say for 20, 30 years, and these are adults that I'm treating, have not slept a sound night in their life. Often only a few hours a night, waking up feeling very tired, often very distressed by that problem sleeping, and who respond very well to treatment for ADHD and sleep much better. We know that people with ADHD have higher rates of primary sleep disorders, things like sleep apnea and restless leg syndrome, and those need to be assessed and treated separate from any ADHD symptoms they might have. But if I hear somebody is snoring or is waking up feeling unrested, I'm going to do a workup or an interview focusing in on primary sleep disorders. The most common sleep pattern in ADHD is difficulty falling asleep, so we call a prolonged sleep onset latency. A very common pattern is somebody coming in saying, I can't fall asleep to 2 a.m. in the morning. I'm so restless, my mind won't shut off. I finally collapse at 2, and then have a lot of difficulty getting up around 6, 7 o'clock when kids need to go to school or they need to get ready for work, and they feel quite tired. People with ADHD tend to need a full night's sleep like the average person, but because of that difficulty getting to sleep, and because of having a higher propensity for restless sleep and more movement during sleep, tend to have less restful sleep. This also sometimes gets clinicians thinking that these folks may have bipolar disorder, by the way, because of the sleep problems. People with bipolar tend to have sleep problems during their mood episodes only, but then come to a normal baseline of average sleep most of the time. People with ADHD have chronically problematic sleep that goes on, again, pretty much unchanged for months or years. When we're asking about childhood history, other than the symptoms that they may have had as children, we're going to ask about other kind of related issues, including in preschool, kids may start to have poor peer and group interactions and disruptive behavior. As they get into school, you might hear this underachiever label be assigned to them. Their routines might be disrupted, difficulty getting to sleep because of high energy, difficulty toilet training, difficulty with handwriting. In adolescence, they may be perceived as more immature than peers, having more conflict with parents, engaging in higher risk activities like unprotected sex or frequent sex partners, reckless driving. Substance use comes in often pretty early. I'd say the average person that I treat for ADHD describes having used some substance by the age of 10, 11, 12 years old. Often alcohol or nicotine. I had one patient recently who reported onset of marijuana smoking at age 8. And what happens is, if you feel very restless, if you're kind of being shunned by your peer group, not only do you have a ready-made peer group often around substance use, but you start to feel a little more relaxed with the substances that you're using. And of course, in adolescence, we might see even more difficulty with academic performance. It's pretty common to see or hear a story where kids are doing okay, kind of getting along in grammar school, but as they go into middle school and high school, having more and more problems as they're expected to have more independence and do more difficult work. Interestingly, when kids are followed from in research studies, when kids are followed from childhood into adulthood and then asked in adulthood about their childhood history, it's shown that they have very poor recall for their symptoms in childhood. And I generally see this clinically. People can give me kind of vague descriptions, usually of what their childhood was like, but don't have a great recall for what exactly happened. Often people say, I ask them how you did in school. Fine. Well, tell me about school. Well, I could never sit still. I was on an IEP. Finally, they'll give me some details, but the general perception is that things were fine. And this research, what was interesting to me was that at age 30, there seems to be an improvement in recall for whatever reason. Maybe brain maturity, maybe less denial, I don't know, but that is what the research shows. Some people in childhood can compensate pretty well, either because of, they have relatively high intelligence, a very strong work ethic, parents and teachers are able to provide structure for them. So they don't have as much difficulty in their adolescence, but by the time they're in high school or college and they have more independence, you can see real emergence of very difficult to manage symptoms. And there are some risk factors we look for in childhood, things like maternal smoking and alcohol exposure during pregnancy, low birth weight, and psychosocial adversity are all risk factors. ADHD is strongly heritable. When studies are done to, mostly these are what are called twin studies, looking at the genetic contribution versus environmental contribution to ADHD, about 70% of the contribution is genetic. If you have ADHD, there is a 2 to 8-fold increased risk that one of your first-degree relatives will also have it. And it's associated with Tourette's, autism, and learning disabilities. Some people report no ADHD. You ask them, parents, brothers, sisters, cousins, no. But you might see other things in families where ADHD has not been recognized. You might see a prevalence of substance use disorders, criminal history, violence history, mood and anxiety disorders may be diagnosed instead of ADHD, and general poor school and occupational functioning. And still, if you're not seeing that, one thing that can happen is if you ask about medical history, you might find medical causes of what looks like ADHD or something very similar to it. This can be prenatal and perinatal complications, maybe infection during pregnancy, stress during pregnancy, like I mentioned before, substance use by mom during pregnancy, or stress after delivery. Head injuries very commonly present with symptoms that look like ADHD, impulse control, cognition. Brain infections at any age can manifest with difficulties with attention, cognition, and impulse control. Seizure disorders, especially in kids. Sleep disorders at any age can manifest. So people with ADHD have sleep problems, but sleep disorders in and of themselves can cause problems, obviously, with attention, cognition, et cetera. And this is why it's very important to tease out timelines, age of onset of symptoms, et cetera, to try to figure out which is the chicken and which is the egg. Lead toxicity typically presents a clinical picture very similar to ADHD. Tends not to respond very well to the treatments that we use, is what I've generally found, but does look very similar to ADHD. And then thyroid abnormalities, and then many other medical conditions, some medications, and some substance use disorders also can present with symptoms very similar to ADHD. So at this point, I'm going to turn it over to Feyza, and she'll talk about a little bit more about assessment in kids, and then talk about treatment. Thanks.
Thank you. So Joe did a beautiful job outlining all the criteria, the assessment, the differential diagnoses, and then I had a few things to add from the children's world, and I started to make my own slides first, and then I decided I had just this flashback on this wonderful slide prepared by the Vermont Department of Health, partnering with VCHIP and coming with this quality improvement program on assessment and treatment of ADHD across the nation. And I think it's such a beautiful slide. And actually, it's VCHIP, meaning Vermont's children's welfare and improving the quality of their care, but it's even being nationally used. So I decided that this is just a great visual. So and also before I even get there, I also want to add that in children's world, I almost see ADHD as a neurodevelopmental delay rather than a gross psychopathology, because it's not like schizophrenia or bipolar disorder or major depression where there is, again, gross psychopathology. It's more like there's a failure to inhibit in a child. And when I say failure to inhibit, that could be failure to inhibit what I'm saying, failure to inhibit my movements, failure to inhibit my emotions. I think that slide of not a criteria in DSM, as pathetic as it can get really on DSM, is the ADHD criteria. The huge piece of I can't inhibit my emotions is seemingly the biggest problem in a child's world. And everything is actually normal. I mean, the emotion they're having is a normal emotion. If I'm angry, and rightfully angry, what makes me ADHD versus not is the ADHD child turns the anger into a huge meltdown, which the peers may struggle with forgiving, as opposed to a non-ADHD child can say, whoa, hold on, let me fact check, let me talk to mom, let me do this, let me do some deep breathing. And that's exactly the failure to inhibit what you want to do with your body, with your word, with your emotions is the childhood ADHD rather than strict criteria for DSM criteria for ADHD. So I see ADHD as a neurodevelopmental delay, but the delay can be so profound that by the time they catch up, their peers are 10 years ahead of them. Then it turns into, wow, I just failed to launch, I just lost a job, I couldn't graduate. So I really want us to conceptualize ADHD, especially from a child's standpoint, as it is a failure to inhibit yourself, whether it's an emotion or a behavior or an impulse, which then causes critical levels of impairment. So that failing to inhibit child can trigger a response, and that's where my slide starts here. So whether you call it impulsivity or hyperactivity or inattentive symptoms, somewhere along the line, the system gets triggered. In child world, it's not an adult walking into an office, it's the community, the school, and the home all coming together to make a child's world. So some part of that system based on one of these, some part of that system based on one of these criteria gets triggered. It could be, let's start with the school. It could be the school being not triggered, activated, I should use, being activated with some concerns to say something is off. This child is falling behind. It could be academic falling behind, or it could be social or emotional falling behind. But once the school has those concerns and they start scratching their heads about what's going on, that's one system of care in a children's world. So what the school does about it could be starting with just the home school communication. And the school can be, by the way, as early as preschool. It could be at age 3, the preschool teacher thinking about, whoa, is this a really wild energy boy, or is this a kid who really will be cooking into a full-blown ADHD in kindergarten, where he now needs to sit on the rock for 10 minutes and listen to the teacher. So once the school system gets triggered, typically it starts between the teacher and the home, the parent. And then if the concerns are big enough, it then becomes okay, let's do some tests and measurings to understand what's the standard expectations from a child this age and where this child is failing. If it seems to be an educational falling behind, that's where Joe mentioned that I may ask for more psychological testing. So that's more to test, okay, you meet the criteria, but at the same time, we want to understand where your cognitive skills are, and are the expectations too high? So that's why you're becoming hyper and impulsive, because the thing, we're giving you 2 + 2, 4. A first grader should be able to do that. But if a first grader is absolutely not there cognitively, 2 + 2, 4 could be like Chinese to that child. And that could be the reason why the child is bolting or running around the classroom, not necessarily because he's impulsive. So that's where the school system in a question mark ADHD kid gets activated to understand the learning profile. And that's where the special educator team kicks in. The school psychologist kicks in to test that brain's profile to understand if this is really hyperactive impulsive versus there's something else going on. So that's the school piece. And then the school may turn this into, if the academic failure or falling behind is high or bad enough, then the child needs a specialized education team, an IEP. Or if the failing is not bad enough, then the child can be accommodated by a 504. I will not get too much into those, but one is more, so the 504 plan is more to access the education coming from the ADA legislation, and the IEP is more like an individualized educational plan coming from the Individuals with Disabilities Act Part B. We can get more into detail if you have any questions about that. So that's how the school gets activated in terms of concerns, assessments, and educational plans. Now, if all these at some part of this process starts failing, typically the medical home starts getting activated. And that's where our pediatricians in Vermont are so skilled. I have to say it's impressive. So mostly it starts in the medical home, and then if it's complicated enough for a various number of reasons, psychiatrists could be pulled into the picture. But regardless, the assessment, this takes, I would say, a good 4 hours for me to then have a second session, 3 to 4 hours, to then sit with the family for a second follow-up visit to explain all my findings to the family. And why is it so complicated in a child? Because it really starts from not even baby in the belly. It starts with, how was your childhood, mama, and how was your childhood, daddy? It starts really even with the parenting skills or the way the parents were parented and their childhood, and that's impacting even the pregnancy, and then the baby in the belly, and then from that point on to the present is every single detail that matters in a child's assessment. And the assessment has to be multi-informant, meaning I have to talk to the teacher, the mom, the dad, the grandparent, if the child is spending the whole weekend there, the daycare provider. So all the information comes together to assess a child because there are so many other factors that could be an ADHD look-alike, and it's easy to misdiagnose. And then, of course, in the family system, there's some activation where they're trying to figure out the medical piece of it, getting the diagnoses, the educational piece of it, and all three chambers come together for the treatment planning and then the ongoing assessment of the, once you implement the plan, is it successful or not? That's an ongoing process. So this is, if you just Google this, this will pop up. If it's a beautiful visual, and it's just online. If you Google, you will find the slide. So I can't talk enough about childhood trauma being an ADHD lookalike. Again, Joe talked a lot about ADHD differential diagnoses, but I can't help myself, but I couldn't help myself but create like a separate slide on this because it's so relevant in our work. And I guess I would say at least once a week, if not more, between the two clinics I work, I have a child that's referred to me either already labeled with ADHD, and I'm saying labeled because it's really easy to use. I'm a little bit salty about that ADHD acronym because it reflects maybe, I don't know, 50% is fair enough to say what ADHD really is in a child's world. And then it leads to the, oh, it's a myth. Oh, the drug companies. Oh, yeah, you people, you mental health world. Of course, everything is, it is a real thing. But then it's so easy to misdiagnose, then rightfully leads the community with believing sometimes it's a myth. And this is one of the biggest reasons that children with complex trauma, and we use this term in childhood trauma instead of PTSD, because childhood trauma is a little bit different from my veteran who comes back from Afghanistan and having flashbacks and nightmares. Childhood trauma looks like I'm gonna trash the room in a very hyperactive and impulsive way, and in the meantime, when you're teaching me math, I will be coloring pictures of guns, super inattentively. Boom, meets the criteria ADHD. It really is not, and that is, it's, I guess, my soft spot when those kids do not get the trauma-informed care they deserve, and instead they get labeled with ADHD and then given medication, and maybe it may even make matters worse. So I can't emphasize enough not to miss the importance of childhood trauma and being trauma-informed caregivers when assessing a child that absolutely meets all the DSM criteria for ADHD. So that said, I will segue into the treatment. And I want all of us to focus on the meds and more. And I will tell you why I really want to focus on the more piece. So I want to introduce, so these 3 slides will just introduce you. Just forget about ADHD for 3 minutes for me, please. And I'll introduce a couple of concepts to you. And that will be my introduction to how we think about treatment of ADHD. So here are these 3 concepts. So in a human brain, so this fancy testing called EEG, right? You hook up with cables and all the electrical activity in the brain gets measured. That was discovered in early 19s. And the doctor, Dr. Berger in Germany, who discovered EEG, made a huge effort to tell the physician's world to say, the brain is active all the time. The brain is active all the time, even when we're sleeping or even when we're not sleeping but not doing anything, just sitting there, the brain is active all the time. And that information got ignored for the longest time, all the way until 2000s, where the neurologists started to focus on this and really started to acknowledge more and more that when you're sitting, like snoozing on your chair right now because this talk is so boring, or you're ruminating on something, doing nothing, there is no external engagement, there is no conversation going on, there is no attention-demanding task in your hand, and you're just sitting there and being, the brain is firing. And that's called the default mode network. And that firing brain can be absolutely inattentive. So put that brain in a child trying to be in a language arts class. All right? So keep that in mind. Let's move on. So the brain is firing even when I'm either not attending to anything or I'm ruminating. I'm depressed and ruminating because I'm a failure, I suck, life sucks, I'd better be off dead. Or I'm anxious and ruminating. I'm going to give a talk, I'm shaking, what am I going to do? I'm going to fail. Ruminating or doing nothing, being ADHD inattentive type. My brain is firing. So great piece of information. Let's move on. Then there's a part of the brain that's absolutely the opposite. It's called the task-positive brain. And that is the brain where gets activated when you're doing that worksheet, when you're thinking, when you're knitting, crocheting, talking, engaging. That's the part of the brain. I won't get into the fancy anatomy names, but that's the part of the brain that gets activated. Now, the trick is those two parts of the brain are mutually exclusive. So when this is active, this is gone. And when this is active, this is gone. So it's almost like inhaling and exhaling. If I'm using my inhaling muscles, I can't exhale at the same time. I can only do one at the same time, right? So the whole idea behind the treatment of ADHD is to find the most beautiful balance between the firing, inattentive, doing nothing, or doing something unhealthy brain, such as ruminating, and the task-positive brain. So that's the whole concept of treatment of ADHD. Does that all make sense? So once you find that balance, that's where we want to go, especially with the children. Because by the time you hit adulthood, you already figured out some skills to kind of shut down the default mode brain and then activate the task positive. You've been in therapy, you failed and learned from experience, your mom gave you your skills, you've figured your own ways of, I'm gonna put stickies everywhere, I'm gonna set my reminders, I have colored folders. You will find your own ways as an adult, most probably, and you will channel your skills into something that matches with your skills. But as an adult, as a child, this is the thing that we really want to do to the children and try to help them to balance the default mode brain with the task-positive brain. So that's the whole concept behind the ADHD treatment in the modern psychiatry world. And it's not only possible with Ritalin, right? There is much more going into that, if only it was that possible. Despite ADHD medications being one of the most effective and helpful medications in psychiatry, like you use them, and if you're barking up the right tree, they work and they make a night and day difference within the day. Despite that fact, especially in a young brain that has 27 to 30 years to complete its maturation, it's not only about the medications, and there is much more into treatment that helps the balance. So I just wanted to talk about the concept of how I see ADHD treatment rather than talking about medications and therapy modules. I hope that was helpful. The third concept I want to introduce is the epigenetics. Hot word, right? Joe didn't put in his objectives that you're going to leave the room more smart. You will know what epigenetics mean, because it's a very hot word and it's lots of research is going on this. So the easiest way to explain this is the chromosomes get coiled up onto each other, and then they get further wrapped up onto each other. That then forms your genetic makeup, right? And that's who you are. Mentally, physically, you have blue eyes, you have anxiety, you have a certain stature. That's all your genes, it's there. Now, we increasingly understand that external factors do something to your genetic makeup. To just look at this pink part here. It's just there sleeping somewhere absolutely inactive in your genetic makeup. External factors, whether it's good or bad, may wake up the bear and gets a part of your genes totally activated and turn into some pathology. So that's where we say genetic ADHD versus environmentally caused ADHD. So it's not like I don't have it, but the environment makes me have it. It's more like something in my environment. And the environment, again, remember, starts with baby in the belly. It starts with the in utero environment, and it could be all the way to early childhood years, the formative years, and then the adolescence. Something may wake up the bear, and that child may look like ADHD. Now, bringing the balance, bringing the balance sometimes also comes through not balancing those two parts of the brain, but also through, that's a reversible process. So if I woke up the bear by any environmental stress, let's say childhood trauma, there is also ways to kind of put the bear back to hibernation mode and deactivate that gene. So that's the third concept in how we think about treatment of ADHD. You can, if a child, life just threw big chunks of mess at a child and totally woke up through epigenetics, woke up a sleeping bear, through some interventions, it is possible to reverse that process. And that's the third concept that I wanted to introduce about treatment of ADHD. I really want to focus on the fact that it's not only medications. And it's a common reason why sometimes, especially in children, treatment fails, because fails in quote, because the expectation is that I have a magic pill, Johnny will take the pill, life will be cream and peaches. It just doesn't work that way. And I really wanted to introduce those three concepts to make sure we all understand why. So the meds are 70% effective. They really work. If we diagnose smartly and prescribe smartly, they really do work. And despite that, I want to emphasize the fact that they are not the only treatment module. They do not, why do we want to focus on them more, despite the fact that they're this effective? I could outline the reasons, the main reasons as, one, they may alleviate the symptoms. The child or the adult may look more attentive, less impulsive, and less hyperactive, and can regulate the emotions better, but they may still have functional impairment if we do only medications. And then in children's world, some families, some parents are just like, you're not medicating my child, and we can only respect that, but that shouldn't leave me with despair of, oh my goodness, now what am I going to do? Because there are other options. And then the side effects that we'll talk about, they're real. Some children and adults can really not tolerate the side effects. I just put this slide over here to just make sure we understand again one more time that it is not only hyperactive and impulsive and I can't pay attention. It's way more than that. And that's under the umbrella of executive functioning. So that these are the symptoms that may not be necessarily super responsive to medications. Even if the medications can help them to sit and focus, they may still struggle with organizing, prioritizing, focusing, shifting the attention. They may focus perfectly, but now they can't shift the attention. That's a problem. And it's not a medication failure. It's now brain is such a miraculous organ that I don't know what we're going to discover in 50 years that will target this maybe. But from what we know so far, we cannot target these things with medications. Regulating alertness. Joe had the beautiful slide about sleepiness. ADHD people do snooze all the time if they're not stimulated by their external input. The moment that's like video games, for example, how many times do I get a parent that says, they can play Minecraft 6 hours, all right? What do you mean they're inattentive? Because that's an internal stimulus. The moment you unplug that, they're literally snoozing because they cannot modulate their alertness, just like they cannot modulate their attention. Managing frustration, the emotional piece I talked about. Working memory, it's a huge piece. The working memory, and that's where the testings, we don't really order those tests to confirm the diagnosis, but if we have them at hand because the school already tested the child, we typically see that they are working memory, which means I will look at my environment, get the information, bring it to this juicy part of my brain that thinks, weigh the consequences, stop, think, and implement an action plan. That's the working memory, and that is very low in children with ADHD, as well as the processing speed. And those don't necessarily get fixed with the medications. And then the self-regulating. Like if if there was a squirrel running here, we would all say, like, oops, squirrel, we would all do that. That's okay and normal. So where the self-regulation piece comes in is the ADHD adult here would run and start chasing the squirrel. So that's where the self-regulation comes in. Again, that may be one more thing that the medications may not address nicely. So we do talk about psychoeducating the families or the individual if he or she is an adult. There are certain psychotherapy options. Joe, do you want to chime in a little bit? This is, I believe, your slide, right?
Yep. So to advance
Yeah.
to here. So here.
Yeah.
So again, just what you were talking about, Feyza, that we're not simply offering a person a prescription. We're going to start with talking about the condition, the things we've been already talking about today. We'll give a summary of that. We'll talk about the potential treatments. Some psychotherapies have been developed, including cognitive behavioral therapy for ADHD, coaching. Sometimes if, as I mentioned before, there are more relationship issues, and therefore we're going to do couples and family counseling or refer people for that. We want to give people psychosocial supports. This might involve voc rehab or school and workplace accommodations. There are often more medical problems happening in people with ADHD, so we're going to make sure those medical conditions are well treated. And then finally, we're going to talk about a plan for treatment with pharmacologic agents, medications.
Right. So these are the things that bring that nice balance to that brain. So all these 8 modules seem to be super common sense, but I can't emphasize enough how many times I may sit with a child that never read once with a parent, or a very sedentary adult that seems to be ADHD. And once you bring exercise in their life, they really do, and this is repeatedly shown in research, that exercise increases cognitive, it's almost like a cognitive enhancer. The moment you bring, and it's not vigorous exercise, you bring regular exercise into a child's or adult's life, that's where the cognitive impairment starts to, not the intellectual disability, but all those processing speed, working memory seems to be improving. One thing that really makes me livid is the intervention of taking recess away from children or finding PE useless and filling it up with more work. That's nonsense. That's just against science, and in my mind, it should be literally illegal to take recess away from a child. It's like sabotaging the ADHD brain. Same with music. Music, not necessarily passively listening to the music, but actively picking an instrument and playing it and working on the instrument, even if it's 5 minutes a day. That's synchronizing your fingers, sending it to the brain, and being proud of yourself and establishing something that increases self-esteem. That seems to be, research shows, decreasing scores in inattentive and hyperactive impulsive symptoms. Mindfulness is and it could be yoga, it could be just sitting there and being, whatever your thing is, any kind of breathing, meditation, any kind of mindfulness exercise is actually, that balance is the biggest in this list of what brings the balance to that brain. So just forcing yourself to stop and just breathe for 3 minutes seem to be extremely effective. Psychiatry is more and more becoming aware of the importance of nutrition, the micronutrients on the brain. Sleep, I won't emphasize more than Joe already did. It's impaired in ADHD, so regulating it really helps alleviating the symptoms. Reading, especially in children with, it's not only reading by yourself, but also reading with a parent if you're young enough is extremely helpful. Community involvement, mentorship, giving, and relationships, they do, most of the children and adults, they do actually realize their impairment. They cannot make sense of it sometimes, but they do realize. So being a part of the community is so hard for them that it turns into a vicious cycle of, I'm messing up. The more I'm messing up, the more I'm rejected. The more I'm rejected, the more horrible I feel. Then I don't want to even do better anymore. So it turns into the cycle. So just hooking them up with a big sister, big brother for an hour is huge in their lives, especially if they're coming from a more struggling family structure. It's as important, if not more important, than medication treatment for a child with ADHD. And then, I mean, it's kind of a salty slide, but I think I'm trying to make a point that we do have sometimes expectations that the sick child treat the child, whereas, for example, one-on-one time with a parent with no siblings around, no TV or other screen open, just one-on-one quality time, sitting with your child for 10 minutes, like ridiculous, right? 10 minutes a day. Research shows that that decreases the ADHD symptoms. So that said, yes, the medications work very well. If all these other factors are in place, I'm not trying to say that you leave the medications to the end. Actually, I'm very quick to prescribe if I'm pretty positive about the diagnosis. It's effective. So what do the medications do? Let me come back to this. So from what we know so far, the science tells us that ADHD is a dopamine deficiency in certain parts of the brain, especially in the frontal lobe, prefrontal cortex. So what the medications do is, the stimulants, the first-line treatment medications, the stimulants, what they do is, so the methylphenidate group increases the dopamine secretion, and the amphetamines also decrease the trashing of the dopamine. So they all do the same thing. So all these brand names, the Ritalin, Metadate, Concerta, all the brand names actually basically do the same thing in your brain, which is increasing the dopamine in your part of the brain that's not functioning appropriately or lagging behind, which is the prefrontal cortex. So then if they're all doing the same thing, then what makes them different, and how do I pick the right medication? It's really mostly about how they are engineered in a way. So for example, with the Adderall, it's little pellets. It's a little pellet in the center and then onion layers put around them, so around the pellet, and it gradually gets released during the day. With Concerta, for example, again, this is methylphenidate, this is amphetamine, this is methylphenidate. All of them are. For example, the difference for this one is there's a laser hole here, there's a sponge here, you swallow the pill, the belly juice gets in the pill, starts swallowing it, and it pushes the methylphenidate gradually out through the day. So it's real, and whereas in the Ritalin, it's nothing around the Ritalin, it's just the Ritalin, you swallow it, it gets released. It's really the way they are engineered. Sometimes there are nuances. This is Vyvanse, for example. Vyvanse is a prodrug. What the company produces is a prodrug. It goes in the body. It adds up to an enzyme, and it turns into an ADHD medication. But regardless, it's a common question that, well, how do you pick the medication? Or you're not giving Ritalin to my child. Well, Concerta is really Ritalin. It's just long-acting, right? There is that myth about, I'm not sure if that's your experience in the adult world too, but Ritalin and Adderall seem to be the bad guys, whereas they really all do the same thing. And how we pick the medication is, in terms of with that engineering, how we pick it is, well, first of all, you gotta love managed care if you're a physician, right? They tend to initially pay for the first liners, and that makes sense. It's the cost efficiency that kind of leads the way a little bit. But otherwise, if I'm sitting with a child that has 3 hours of preschool or 3 hours of Head Start, and the symptoms are bad enough that I have to medicate at age 4.5, 5, then I may pick although ADHD is a life issue, not only a school issue, but if the major problems are due to the academic demands at school, I may pick a shortest acting one. If the whole day is a struggle, I may pick a longer acting one. Hold on, let me do this. Okay, so the delivery system, long actings are preferred to start with. In adults, in children, I may have to be a little bit more mindful. The absorption of the medicines may widely vary between people. Sometimes it turns into a try and see what the body will do with the medication or the medication will do to the body thing. Sometimes I get asked about, do we do genetic testing to decide the dose, but typically the clinical trial and error phases do let me figure out the answer. The frequency, if it's short acting, some patients may say we don't want to do 2-3 times a day, so that's where the long-acting ones kick in. And you look at the clinical response to figure out the right dose. There is no milligram per kilogram necessarily with the stimulants. How are we doing with time? Okay, we're almost done, right? So common side effects are similar to excessive caffeine. It definitely messes up with sleep and appetite. Those are will happen. There is no way out kind of side effects, but it's typically within the first year of the medication being used. Then the children typically adapt to it, and no children turns into failure to thrive because their appetite is suppressed by the stimulants. They adapt to it. And giving them with breakfast after a nice protein-rich breakfast, and then catching up with dinner typically seems to take care of that problem. Headache, irritability, jitteriness, sweating, tremors, muscle spasms, nausea is a common one. Decreased appetite, again, will happen, but most typically after the initial 5-6 months, the first year, children get adapt to it. And then insomnia, definitely kids struggle with going to sleep with stimulants. Tolerance develops quickly. That's can be absent initially, but present at the higher dose. Yeah, I'll pass to this. I'll just let you relax a little bit with this. Sometimes we want them to focus and then they hyper-focus. If this doesn't wake you up, I'm not sure what will. Nobody's laughing. I love Kelvin. All right. So, they may increase blood pressure. So we regularly keep the patient's blood pressures in check. There used to be a requirement for EKG being taken each time before we start a trial. Afterwards, research showed that if there's an anatomical malformation in the heart is when we're really worried about it. And if there's a sudden cardiac death history in the family, if there's unexplained fainting, if there's exertional chest pain, and family history of sudden death, then we definitely ask for the EKG, but it is not required to be a pre-screening procedure before prescribing stimulants anymore. So no baseline EKG is required. It lowers the threshold for seizures, but I do work with neurologist friends, and it's really extremely rare that they tell me, be cautious, Feyza, don't prescribe stimulants. I do even have irretractable seizure cases that I can prescribe stimulants successfully. But we work hand to hand with the neurologist. It may trigger psychosis if you already have, again, a gene there that's not activated. sometimes stimulants can trigger psychotic symptoms. Then there are the non-stimulant medications, which we say second-line medications, and those are working not with dopamine, but with norepinephrine in the brain. That's a neurochemical that increases attention span and hyperactive impulsive symptoms. And Strattera would be the FDA-approved one for increasing norepinephrine for ADHD treatment. Wellbutrin, clonidine, guanfacine, and really rare use, really old and high side effect profile medications, tricyclic antidepressants. We don't usually prescribe them for ADHD anymore, and modafinil. And that's where Joe takes over again.
Yeah, I'm gonna,
Okay.
in the interest of time
Yep.
and allowing time for questions, I'm going to just go through these very quickly. And basically, ADHD medications in pregnancy are pretty safe. Some recent studies show that there might be some slight increased risk of cardiac malformations with methylphenidate and lower APGAR scores at birth. Amphetamines seem to be a bit safer. Generally, when I'm working with a mom who's pregnant, I'm going to recommend minimizing dose, even stopping medication during pregnancy if possible, just to keep the risk at the absolute minimum. But some people can't tolerate that, and some women will have a really hard time functioning without it. And so we're going to find the lowest possible dose that'll get them through their pregnancy. Generally, we recommend against breastfeeding while taking these medications. At one point, there was a diet called the Feingold diet that had a bunch of things you're supposed to remove, and it was touted as being effective for ADHD. Studies done on that show that's not true. But removing preservatives and food coloring has been shown in ADHD and non-ADHD kids to decrease hyperactivity, impulsivity, and attentiveness. So I think it's safe to recommend that we probably all should avoid these things. They're not good for us. But certainly if somebody's having issues with ADHD-type symptoms, that they should avoid them. And other things like caffeine, refined sugars, et cetera, some kids are more sensitive to those, and those should be avoided. I'm not going to go through these slides again in the interest of time, but just to say that concurrent substance use in ADHD extremely high, often as a way of self-medicating these symptoms. But also, somewhat interestingly, that people with ADHD don't seem to have higher rates of stimulant use disorders than the average population. One might think that, but that's not the case. When looking at risk of treatment, some people might wonder if you're giving a stimulant during childhood, could that increase the risk for further substance use later on? Studies generally show that either treatment is either protective or has no effect on eventual substance use. I'm not aware of any data showing that actually increases the risk of substance use disorders later. There is significant data showing that high school and college-age kids with ADHD may misuse their prescribed medication and may divert it. And so monitoring that age group is pretty important, I would say. I don't generally treat that population, but if I were, I would be very careful about medications in high school age and college age kids. And then, with the opioid use epidemic being such a problem and really having its most recent kind of flare up, the root of that was prescription opioids. I'm certainly concerned about any possibly abusable substance that I'm prescribing. And am I contributing to a use epidemic with, in this case, stimulants? And the research shows that there's pretty considerable misuse and diversion, again, amongst high school and college-age kids, somewhere in the range of what, at least in college kids, of opioid misuse rates. However, studies also show that less than 1% of non-ADHD individuals misuse stimulants more than 6 times in their life. So they might be used as a performance-enhancing agent at some point during their school career, but few go on to use it routinely. Thank you for your time and attention, and welcome any questions at this time. No, it's fine. So we've got 15 minutes for any questions.
So I currently work in our local drug treatment court, and the co-occurring disorder track is by far the hardest to work with. Okay. And we are really struggling with dealing with the interplay of the ADHD, how to medicate that while we're trying to treat the opioid use disorder. So, any suggestions?
Yes, and if couldn't hear that at home, the question was treating co-occurring disorders in a treatment court situation, or anytime there is a co-occurring substance disorder. It's very challenging, is what I'll say. Doing so very cautiously is important, I would say. Doing very careful monitoring of if you're going to use a stimulant medication, careful monitoring of that with pill counts, something I routinely do. Doing routine urine drug screens as part of treatment is very important. With that being said, some people will be very successful with treatment and other people will not. The research on ADHD and people in treatment with people with co-occurring use disorders shows that they tend to have far more dismal outcomes in general. Whereas, as Feyza said, in non-co-occurring populations, response rates of 70 to 80% are common. In treatment with co-occurring, in people with co-occurring use disorders, sometimes there's no difference from ADHD treatment and placebo. So you have to have a more cautious view as far as outcome and be very careful about keeping medications safe, I would say. And it really is a case-by-case basis. I try to offer treatment to folks who have co-occurring substance use disorders because I have seen very successful outcomes, but I'm definitely more cautious. And so I would say, in general, what I would also say is working with a provider who's very comfortable treating people with co-occurring substance use is very important. I think a general primary care practitioner, for example, would not be that comfortable and may have some difficulty doing that.
Are there any gender-related propensity to ADHD?
Gender-related.
Does one sex or the other have a greater propensity to developing ADHD?
Yeah, it's a 2-to-1 male to female ratio.
2 to 1.
Generally, yeah.
What would that be due to? Is there a clinical reason for that?
I don't know. I think that, and I'm not sure that's the case, maybe you can answer that. I'm not sure if males may just have a higher propensity towards hyperactivity, impulsivity related
Right.
to women. That might be related to testosterone, but I'm not aware of what
Right.
that
So
may be.
one theory is that there's a referral bias in that in those research studies too, in that a teacher or a school or a family would be more quick to refer a hyperactive, impulsive, disruptive boy to a clinic as opposed to the good girl with lots of moral values to do the work, studying maybe 4 hours as opposed to 1 hour. That female child doesn't quickly get referred to the clinic, as opposed to the really high destructive boy gets quickly referred to the clinic. So that may be a referral bias too, is one of the theories to explain that.
So the boy might be more on the two symptoms, be more to the hyperactivity, whereas the girl might be more inattentive.
Correct. And then that that changes the referral rates.
We won't see the latter so much.
We do, but they are less prioritized to be referred immediately.
In adults, the rate, those kind of dichotomies of more inattentiveness in girls and hyperactivity, impulsivity in boys tends to be erased. Most adults present as having combined symptoms by the time they get to adulthood, and that male-female disparity decreases.
Here and then here.
Actually, I have two questions. The first question was regarding the medication slide. Is that listed in any particular order? Is it like from most used or most effective that you've seen?
No, and
Nope.
there really is no guidance as far as the two major stimulant categories, methylphenidate and amphetamine. There's no research to indicate, or even my clinical experience would not indicate that anyone is more effective than the other. It really is about a blend of, every person seems to have medications they tolerate better, and tolerability tends for me to be the main issue. Can I find something that you're going to tolerate, that's going to last all day? And it's trial and error.
The other question I had is I actually have a 5-year-old daughter who presented at 3 years old, and she was finally formally diagnosed at about 4.5. So she started medication, and we have seen a huge difference. With her, she has a genetic mutation, and it kind of goes to your epigenetics analysis. I was wondering, it's not necessarily the awakening, but she has a genetic mutation of one of her neurological genes. And the gentleman in the front row mentioned people sometimes developing ADHD, but is it something that is, like you've mentioned before, that it's primarily genetic? And will it be, with treatment, is it something that will not be seen in adulthood?
Right. So certain genetic disorders do have increased rates of certain disorders. That's true for ADHD too. That does not change the treatment course just because it's part of a genetic condition. It's the same treatment guidelines. And I don't really know if the prognosis is better or worse just because it's part of a syndrome, a genetic syndrome. I will have to look that up, but it certainly doesn't change the treatment course. If the prognosis is better or worse, I really will have to look that up. Did that answer your question?
Can you use a microphone because I want people at home to hear.
Just a follow-up to the question regarding the ratio of male to female. If it's 2 to 1, and you're saying that there's a tremendous genetic overlay to this, might it not be an X-linked problem genetically?
I don't believe there's any evidence to show that it's X-linked. I'm sure Feyza, do you?
No, I agree.
With that second line of non-stimulant medications, do they have anything in common with each other, these various medications, other than they seem to work? I mean, is there any idea what the mechanism is?
Right, so I had to pass through that slide quickly, but their mechanism of actions in terms of what they do to the brain is totally different.
Yeah,
And sometimes
is it the same with all of them?
it's not. They're all three are so tamoxifen, Wellbutrin, and the alpha agonists, the clonidine and the guanfacine. They have absolutely different mechanisms of actions, and there are so many accidental discoveries in psychiatry that we try for something. Clonidine, for example, was tried for blood pressure, and then it was figured out really accidentally that it makes people less anxious, less hyperactive, less impulsive. And it switched indications, then it was more studied for those symptoms and was found to be effective. But their mechanism of actions are absolutely different from each other and also from the stimulants too.
I'll just say, kind of going back to your previous question about treating people with co-occurring substance use disorders, the second-line agents are often where we'll start because they tend to be safer, they're non-abusable. So because they don't have the same activity in parts of the brain responsible for addiction.
Thank you. In addition to yourselves, does the Howard Center or anybody maintain a list of therapists in the area who specialize in this?
I personally have a list of a few therapists who have told me that they specialize in it. I'm not aware of any actually who accept insurance at this time. Most of them are out of pocket, and they consider themselves ADHD specialists.
The way you said that makes me think that you don't know that they are or think that they might not be.
I'm not sure what you're asking. that they are ADHD specialists?
No, what you said is they consider them, when you said they consider themselves ADHD, the way you said that makes me think that.
No, I didn't mean to indicate anything other than that they consider. I trust that they are.
Okay, thank you.
What they are is who they are. But again, I'm not aware of anyone who takes insurance, and that can be a barrier.
That can be. And if you get treated at the Howard Center, they do take insurance?
Yes.
Thank you.
And if you don't have insurance, we'll see you as well. We'll do sliding scales.
Okay, thank you.
Yes, absolutely.
Behind you. I've never used a microphone before, so. I want to go back to the section where you talk about the default mode network. I think it was you, Feyza, who was talking about it, and the task positive self-regulating. Mm-hmm. I didn't understand whether, is it typical for default mode network, is that an issue exclusive to people with ADHD? In other words, are you saying that that is overactive? When you're in the sort of relaxed mode, you're still functioning, and that's more, this diagram is more like the exception that's more typical of people with ADHD.
The typical state in ADHD is their default mode network is overly active. And their task positive areas of the brain are kind of, and again, because they don't get activated both at the same time, their task positive network tends to be kind of silent. So all those 8 things plus the medication seem to be activating the task positive network over the default mode network. Did I answer the question?
I understood the first part, and I didn't understand the latter part. So it's harder to go from the default mode network to the task positive one. It's harder to make that transition. What am I missing? I'm sorry.
So we want to, so the default mode network is what causes ADHD symptoms. If it's more than acceptable levels, that's what causes the ADHD symptoms. So increasing the task positive network helps you be more positive, more cognitively enhanced, more able to push away the ruminations and the worries and the inattentiveness, more task-oriented, more organized, more focused, less impulsive. So with all the interventions, you can beat the nature of ADHD where the default network is firing. And you can muscle up the task-positive network, and that will alleviate the symptoms.
I got it now. Thank you.
Okay, thank you.
Yeah.
We can take one more, maybe up in the back.
Hi, I'm one of those girls who wasn't diagnosed in high school or grade school. It was about my mid-20s when I got diagnosed, and it's led to a lifetime of trying to negotiate the symptoms and work through them and find medications that work and finding coping mechanisms, which apparently I'd come up with a bunch of them on my own. I didn't even realize it because it was a surprise to me when I got diagnosed. And I'm just wondering if you guys know of any established support groups in the area, because I did do a lot of research trying to find a community of people that I could relate to and talk to about my symptoms and my issues and my struggles. And I kind of found a lack of that in this area. And I know it's Vermont and it's a very small community, and that's probably why. But I'm very rambly because I'm nervous because I hate talking to microphones. So I'm just wondering if you guys had any information about a community of people who are supportive around this.
So, as far as I'm aware, there was a CHAD is a national organization, and there was a support group locally meeting at one time. I'm not sure if they're still meeting, but the way to find out would go to the CHAD website, CHADD, and see if where the local or the closest support group might be. And I think they also have an online support group.
They do.
Yeah.
They do.
Yeah.
I think so.
I believe it's
so.
people and families.
Both caregivers and the patients, I believe so.
And one thing I do want to say before we end, when I was talking about therapists who treat ADHD, I was talking about adult therapists. Our child therapists do treat ADHD here at Howard Center.
Right, but I'm not sure if we have anybody who claims to be specialized in it. We do have, for example, if you go back to that list of 8, we do have therapists who are specialized in parent training, for example, or specialized in art therapy. But I wouldn't say we have anybody that's necessarily specialized in ADHD. It seems, at least not that I know of. If I figure it out, I'll make sure I spread the word.
Can I just say one more thing about that? I'll speak about it.
Yeah, let me get this to you.
Thanks. On the Psychology Today website also, there are many, many profiles of psychologists in this area, and it has what they specialize in. So I don't think it's as limited as it sounded like in the previous conversation. I mean, I think there are a lot of therapists out there doing stuff. They might not be absolute, that might be their 100% thing, but there are people that are very effective and very good at dealing with ADHD that are out there in Vermont. So don't despair.
Thank you, Joe. Thank you, Feyza. Thank you, everyone, for coming. Because we did kind of run out of time, if you do have questions, my email is in the folder. Get them to me, and I will get them to Joe and Feyza and get a response back to you. Please take the time to fill out your feedback. We do use that in selecting topics for future sessions, and we'll see you in the fall. Safe travels.